Welcome to AO Link session 9 here, Polytrauma. We're going to get started. So for those who have not tuned in or those who have, AO Link is a webinar series dedicated to medical students. And this is the acronym. And tonight we're incorporating listening, integrating, and knowledge. And then you visualize as Taylor, Dr. Aker, and Dr. Davis and I network and talk and collaborate. And so we're happy to have all of y'all join us tonight. We're so thankful for the support of the AO group and our current AO president, Dr. Rout. And Dr. Aker again joins us tonight as the chair of the AO Link series. And I will be leading this session with Taylor on the clickety-clacks, the ones and the twos, answering your questions, keep them coming all night long. So our guest tonight is Dr. Jana Davis, and I'm going to have Jana introduce herself. And on the eve of match day, Jana, would you give a pearl, a tip for those students who are transitioning to being residents in the near future?
Yeah, hi, thanks for having me. I did all my training in the military in San Antonio and then fellowship in Charlotte, and now I'm at Penn State. So what I would say to all the people out there, all your medical students getting ready to have a big day tomorrow, and it's going to sound so trite, but just enjoy it. It goes by so fast. And if you're stressed at every level, there's always going to be something coming up. So just take time to enjoy it. Do something fun before you start residency.
Couldn't agree more. So we're on session 9, Polytrauma. As you see, we've gone through a number of different injuries in the body, and tonight's really the night to put it all together. Again, a reminder: AO Milestones is a website that's noted here that's being developed by the AO that's going to be very, very helpful as you all progress in your surgical training. Again, hit the Q&A box. Taylor's on the ones and the twos, and we love the questions. We crave them. We need them to keep us on point. So again, look out in your email, the link both of this recording, but then to claim your Credly badge as well. And these are all posted on YouTube for your viewing pleasure now or in the future. So to recap, we went over pelvis last week. Taylor did a great job going over the spectrum of injuries that can be present in pelvic fractures. And so we went over the bony anatomy shown here. And then we also went over some of the radiographs and the inlet and the outlet views and what those views can show you in regards to the pelvic anatomy. But then also we showed the Jude views as well, and highlighted these are x-rays that are designed to assess the acetabulum, where the inlet and outlets are for the pelvic ring. And that early on is a really important concept for students to understand. And so we went over the most commonly used classification, the Young Burgess and the APC and LC types of injuries. And then we went over this injury classification as well, the vertical shear. And we went over this case, and I love this case so much because I think it highlights something really unique about this current time in orthopedics, that this is a horrible pelvic ring injury with a lot of displacement, and through 2 incisions this big, this patient is now walking back at work and doing fantastic. So really it's wonderful. And again, I think as we put it all together tonight for Polytrauma, y'all will again see how incredible what we do is. So we went over with pelvis as well, the anatomy, that it's not only the bones, it's also the nerves, the blood vessels, the muscles that are surrounding these bones that we see on the radiographs. And in a case like this one that was shown, there can be many associated injuries, many different teams that are involved as we're taking care of these patients. So this patient had a bladder injury, both intra and extraperitoneal, and then had contrast through their sacral fracture with a nerve root injury, and ultimately was fixed and did well. But those associated injuries are so important to both pick up, treat appropriately, and then for long-term prognosis are critical. So again, we always lean on our AO principles that we've gone over during each session, and these should be like the back of your hand at this point. And so now we get to apply these concepts. And again, Polytrauma, we're bringing it together. We're going over multiple injuries, but really one of the focuses tonight is for y'all to see us interact and maybe disagree. And I just want to put that out as a warning that I may not agree with what Dr. Davis says. I may not agree with Aker, and I know that he definitely won't agree with me. But that's what makes this so fun. I think ultimately you have 4 faculty members who are at places that are seeing a lot of polytrauma and seeing a lot of success in taking care of polytrauma patients. And I think that's a really awesome thing. And again, I don't take it for granted at all that we're living in a time where patients are able to recover and work after these injuries. So these are our learning objectives. We're going to talk about some of the complications. We're going to understand some of the priorities with polytrauma patients. And then we're going to look at some of the parameters that we're using to guide how we're deciding how to treat patients, whether definitive or in a temporizing fashion. And so the evaluation of a polytrauma patient begins in the emergency department. And that's important to consider, particularly that ATLS is a critical component of the evaluation and the treatment of these patients. And so that begins with the primary survey, and that's the ABCs. And we're going to talk about that a little bit more as we go along. But in addition to those early ABCs, we're getting cardiovascular monitoring blood work. We're getting an early portable AP chest and pelvic x-ray. We're assessing the abdomen for injury. And then during this process, resuscitation is ongoing. And typically orthopedics gets involved at that secondary survey portion. So the patient's life has been saved. We're now in the phase of care where we're identifying other injuries and some that may need some definitive care. And so ultimately the polytrauma patient, we're trying to avoid some really big other scary conditions. And first, that's hemorrhage. We have to stop hemorrhage to stop death. But additionally, there's some inflammatory conditions that through our interventions, we could potentially bring on or make worse. And that includes things like multiple organ dysfunction syndrome and acute respiratory distress syndrome. And so we're going to talk about our role as orthopedists in minimizing these complications. And so an important concept with this is the second hit hypothesis. And so as we know, trauma is an inflammatory process, and surgery is also an inflammatory process. And we have to time our interventions that we don't push a patient beyond what they're able to tolerate. And so this process of not necessarily knowing if to operate, but how and maybe when has been ongoing over the past 50 years. So early on, we fixed everything immediately and potentially to the detriment of some patients. And the pendulum swung in the 2000s to damage control orthopedics, where we would minimize fixation and temporize everything. And that was the rule. And now we're in an era of early appropriate care, which is fixing long bones, other axially unstable injuries, and utilizing other metrics to determine when we're going to be able to undergo safe surgery. So again, early total care, early in the 70s, we fixed everything, and we did definitively. There was not provisional fixation that was utilized as frequently at that time. And then this changed to damage control in the 2000s, where provisional was the rule. And so we tried to perform surgeries that provided stability with little bleeding and avoid a second hit. And now we're in this area of early appropriate care, where we're prioritizing injuries that are actually unstable, things like femurs, pelvis, acetabulum, and then using parameters like pH, blood, base excess, lactate, things that I, as a medical student, didn't think that I would necessarily need to think about anymore. But now we use these measures to determine when patients safe for surgery. So we're going to get right into the first case. And so, Jana, this is your case here. And why don't you walk us through this a little bit, what's on this slide, the ABCs, I mentioned that before, but then also, when does orthopedics get involved in a polytrauma patient at your institution? And then is there any of this information from ATLS that's important to you?
Sure. Yeah. So this is a 17-year-old male that came in as an MVC. And before they hit the ERs, y'all have all done your sub-Is, hopefully, or at least some rotations. And if you haven't, when the patient comes in, EMS calls into the ER. And so the trauma activation is kind of done at that point when they decide what the call is, what the injuries are. And so then the alert goes out to the rest of the emergency department. As you said before, at our institution, you get a trauma alert, so everyone knows the trauma is coming, but we're typically not consulted till the secondary survey. And that can be quickly upon arrival if the primary survey is pretty straightforward. It can be hours later sometimes. If they're in the trauma bay, they need a lot of resuscitation, they have to go to the OR. So the timing of that is really dictated by their injuries. And so he came in, and his primary survey was pretty, I mean, he was perfusing. The main thing was he was bleeding from his tibia. Relatively stable, you know, but not too hypotensive, maybe mildly tachycardic, but not unstable. And you can see, I put a picture of his trauma, of an example of like a trauma flow sheet and where they're documenting these injuries, who the recorder is. So where they have deformities, where it's labeled. So in this patient, they have bilateral deformities of both femurs and the right tibia. And they also note any lacerations or abrasions. And so when you're starting your secondary survey, this information is garnered by the primary survey when they kind of look at it. And then you go in and examine the patient at that point.
Hey, Aker, do you all have residents ever get called to one of these, early on primary survey type of things, or is it kind of a similar situation?
Yeah, where I was a resident, we carried a trauma activation pager. And so we were required to respond and kind of be a part of that primary survey and just help out any way we could. If that meant helping move the patient from the EMS board over to the hospital gurney, however, all hands on deck. At my current institution, we do not carry a trauma activation pager and rather wait to be consulted, like Janice said, which in my opinion has pros and cons. I like the idea of all hands on deck and be involved early and often and run towards the problem instead of away from it. And a lot of times, issues in orthopedics come from miscommunication or lack thereof. And so the more you are present, the less likely there are to be any missed injuries, any problems, any delays in communication. But the short answer is no, we don't respond immediately. We do wait for the call.
Yeah, I feel like if it happens, it's informal. It's like, hey, something terrible's coming in. Want to let you guys know. You may want to be there early, putting a sheet on the
Exactly.
pelvis, hip dislocation, plus or minus. Sometimes they kind of give it a whirl. Yeah, I think it's different at different institutions, but it's important to know what happens before we get there. So.
And I think one of the things is it's not a problem until it is a problem, right? So it's not a problem until they're whisked to the OR and there's no AP pelvis. You don't know about the hip that's not reduced or the pelvic injury or whatever. So yeah, I think good or bad, it seems to be what's happening now.
So here you go, Janet. They do get plain films for you before they put the consult in. And so how do you want a resident or a medical student presenting this to you?
Yeah, so luckily this patient was stable enough to actually get some sort of plain films. And as you go kind of through your rotations and your residency, the trauma films are just kind of, you just get what you get their leg as it lies. And so if I had a junior coming to me, I would want him to tell me what they thought they were looking at. So AP right and left femur, location and bone, so mid shaft, femur fracture. And then I would want them to, say if there was comminution or not. By this point, with the x-rays, they should be able to tell me their physical exam that correlates it with it, whether it's open, closed, whether it's perfused.
Bill, I do
Awesome.
think it's important to say just real quick, in the classic teaching, when polytrauma patients hit the door, part of the primary survey, in addition to the ABCDE, is 3 plain film radiographs: the AP pelvis, the chest X-ray, and the lateral C-spine. Now I'm showing my age because that's going back 15, 20 years. But the reason those X-rays were so important is that you could immediately get a sense of some potential life-threatening problems that the patients could be suffering from. Come fast forward to modern times now, almost all of these patients go A, B, C, D, E, and what do they do then? They go straight to the scanner, and in about 3 minutes, we can have a pan scan that can give us even more information than those 3 X-rays. So a lot of institutions have gotten away from just the kind of the surveillance, AP pelvis, chest X-ray, plus the lateral C-spine was always hard with the shoulders in the way. So I'd be surprised if any of y'all's hospitals are still doing those classic 3 X-rays right off the bat, or are you going straight to the scanner?
Yes, but
Yeah,
often straight to the scanner.
Yeah, same here. I mean, I think I remember, in training lateral C-spine, AP pelvis, chest, but we're lucky if we get an AP pelvis. They're really good at getting the chest x-rays most of the time, getting an AP pelvis, although again, that's hit or miss still. But never getting a C-spine x-ray anymore, really. They just go to the truth scanner.
All right. So one helpful way with these polytrauma patients, and we'll do this a few times tonight to keep track of everything, is to list the injuries. So here we have them listed. We got a left closed femoral shaft, closed right femoral shaft, and an open right tibia. So we're pending some tertiary exam, but we get some admission labs. And Jenna, which of these are important to you? And then any surprises in these admission labs?
So I care about their H&H, to know what that is as a starting line at a initial time point, but I will say that's often hemoconcentrated. So possibly falsely elevated in a lot of times, especially depending on what their injuries are. Multiple long bones, you can lose tons of blood in your thigh, liters of blood. So that I would expect that to I would watch that and trend that if you're not going to the OR right away and you're not able to stabilize them for some reason. I care about platelets just for bleeding and coagulation. They usually will do a coagulation profile as well, which I didn't put on there. Lactate is a big one that we'll talk about as a marker for resuscitation or a surrogate to determine the resuscitation status. And then base excess or deficit.
Okay, great. Tim, what do you use? What's your lab choice du jour for understanding resuscitation?
Yeah, it's interesting. At our hospital, over the course of the ensuing hours, especially if you add on a terrible pelvic fracture on this patient, this might be his admission H&H, but 2 hours later, he's down to 8 and 24. An hour after that, he's 7 and 21. And these younger patients can maintain their vitals for a very long time before crashing and really developing hypovolemic shock. So it's not only the raw data of the H&H, but really the trends of these numbers that I like to follow as well. For me, lactate is a really, really big one. So just a spot check of a 1.8 on this kid, that's excellent. It's great to know. That looks pretty good. But if this kid comes in at midnight, and these are his numbers, and we'll probably talk about when he needs to go, but if in 4 hours he's not quite cleared yet, he gets a repeat lactate, and now it's 5, well, it's trending in the wrong direction. So we're missing something. He's more severely injured than we thought. He's under resuscitated. Maybe this is a time to dial in more studies, damage control, orthopedics. It's really about the trends for me, Phil.
Yeah, I think such a critical point, the hemoconcentration, the drift down of the H&H, even in the isolated femur, which as residents, y'all will see a ton of. Those patients often are under resuscitated. It's often the orthopedic resident who's the one who's giving some fluid in the ER to get their lactate from 2.5 down to 1.5 to be ready for surgery. So I think really, really critical concept that you see something like this, 2 bilateral femurs and a tibia. You could almost cover the H&H up and just say this patient is under resuscitated. It's time to start pouring some product into this patient. So I think that's so critical, and as a takeaway, maybe one of the main takeaways from this case. And so, all right, Jenna. So what's the discussion now? 1-8 general surgery. There is waiting for your call to discuss if the patient's clear, and then if the patient is clear, what's your order of operations in this case?
I think one thing you said is super important that I think will be highlighted kind of with each case is, and what Dr. Aker said earlier was communication, like calling the general surgery, the trauma team, talking to them about the patient, because there may be something about their status we don't notice. You'll kind of see that come up as a theme, but a lot of times that takes us, either reaching out and making that first step and saying, hey, this is what we're planning on doing, letting them know what surgeries that you have planned and are, even though, they look resuscitated to us, can we proceed? What do you think about that? So that two-way communication is super important for these patients. In terms of timing, I think it depends on a few things. I think based on his labs that we got, based on his vitals, he was admitted to IMC. If he comes in the morning, he goes next case available OR. If he comes in at midnight, I'd probably put him on for the next day. To that point, we do have an open fracture. So most ER physicians and all that are really good about making sure they get the antibiotics within the hour. But that's something I would expect the resident to look at and know as well, antibiotics and tetanus update. If we were going to delay going to the OR, they need those antibiotics within 60 minutes.
Does
So this,
does the openness of the tibia matter to you? It's a type 2 open. If the resident, pulled out a chunk of grass, if it was worse, would that change the discussion with general surgery at all?
to me, it does. So I expect the residents, when they see them, to rinse them out in the ER and put a dressing on, get it covered up so nothing's exposed. If it is grossly contaminated where there's leaves and grass, I'll be more apt to take that patient in the middle of the night to kind of wash them out.
Yeah, I think it's, again, coming back to the communication. The general surgery team may not know or appreciate some of those details, and you may have boots on the ground to say, hey, I pulled out, a piece of sheet metal from his thigh, or hey, this was in a, horse manure. And that's good. That's some critical information. So as students transitioning into residents, those details, identifying what's important, can actually make a pretty big difference in terms of patient care. So
what are y'all expecting from your residents at your institutions for open fractures? I mean, we're all going to rinse them. Are you having them close them, or are you having just what do y'all have your residents do for open tibias?
we do kind of wet, soft, moist dressing, and that's it. We don't close them or anything like that unless there's some other circumstances. So what do you all do, Taylor?
We loosely close. That's just what they did before I came, and I don't have a strong objection to it. So yeah, I think it's one of those institutional dependent things.
Aker.
I've also heard stories. We don't do anything otherwise fantastic, but I have heard stories, and we've been approached about an IRB involving the use of antibiotic powder in the open fractures in the ER, which we do not do yet. But that's out there. There's evolving evidence that maybe this could help decrease the risks of infection. So stay tuned for more on that topic, I think.
Yeah. All right, Jen, how are
Also,
you?
Phil, I'll
Yeah.
just say, also for completeness sake, if you work at an extremely busy trauma center, even if you have 24/7 access to an operating room, this patient needs ballpark 10 hours of surgery, maybe. I mean, this is a lot of work. So if I'm on call and I have 8 other operative cases that come in, a couple of hip fractures, both bones, and olecranon, an ankle fracture, all of a sudden, this is also not only what's in the patient's best interest, but also kind of the systems-based practice of how do we get these skeletons stabilized and treated and actually dispo all of these patients in this hospital. That there's only so many of me and my partners, there's only so many operating rooms. So maybe temporizing some of these injuries makes sense so that I can get grandma's fractures fixed as well. And yes, that puts him at risk for more anesthesias, more trips to the operating room. But there's a lot going on with these patients physiologically, but also from a systems-based issue in big hospital systems.
Yeah, I think it is often complex. If one of these was a intra-articular distal femur with a Hoffa, it's not the same as a midshaft, which is not the same as a terrible, pertroch, subtroch that's going to take more time. So I think so many critical points, and again, why I think we love talking about these types of cases, because the offshoots are endless, and that just makes us
we could really go down the rabbit hole on this one.
All right, Jana, bring us back to reality. So, how are you thinking about sequencing this patient, and then how much are you going to do? And we'll say in a setting where you had a quiet night otherwise. This is a PGY2's dream has just walked in. So walk us through it.
It's a good day for the junior resident for sure. And I'm nice and rested, so I'm super patient. They're going to get to do every step. So it'll be a great day for them. But when I look at this and these injuries and this constellation of injuries, my general order of operations is long bones and open fractures to take priority with pelvis. Okay, well, we have both long bone and open fracture. So for this patient, we have that on one side. So I would be more apt to start on the side with more injuries when we first get to the OR. So I know if I do one side and let's say, you know, I get tired or other stuff comes in, I can always temporize the contralateral side if I need to. And so I would usually start with the side that requires more attention and more work. That's kind of my how I've worked out. It seems to work for me in our institution. With that being said, if we're going to start on the right-hand side in the setting of a femur and a tibia, we're going to be supine. So I think you have to kind of think about when you're a resident, how you're going to post this. You're obviously going to ask your attending, but what table you're going to post on, what's your position, especially in polytrauma patients, because there's a lot of times when you're going to be changing your position that you would normally do based on their injuries. So isolated femur, I'm a fan of the fracture table or HANA table or whatever you have. Femoral shaft, tibial shaft, just supine with traction to kind of get length. So I know we're going to be supine with this one with all the injuries. In terms of doing the femur, in fact, if you have a femur tibia, for me, I find it easier to do the tibia first because you're going to get that traction and put the leg over either a triangle or pull traction somehow. And that happens to be the open one anyway. So I would start on the right tibia on this one. I don't know if y'all have any other thoughts or y'all would attack it differently.
What do you think, Aker? What would you do?
Man, I've just got so much to say on this topic, but I'll try to keep it short and sweet. One thing I would say is I would start with the femurs. I would probably do a quick and dirty I&D, debridement and irrigation of the tibia, and just leave it for now. Because yes, wounds and gross contamination, infection, these are bad, but these are bad long term. They're not bad in the immediacy of this patient surviving this event. So we do know that stabilization of the femurs does make a difference for survivability in the acute setting. So I want to stabilize his femurs as quickly as I can, be that with an external fixator or nails. Generally speaking, I would compare and contrast the fractures of the two femurs, and I would opt to do the more straightforward side first, the cleaner, simpler fracture, to where you could say, well, if I do a retrograde nail on the right side, there's a clean read. This is going to be a 10 by 380 retrograde nail. And then you already know it's going to be a 10 by 380 on the other side, even if there's a large zone of comminution and you can't really assess the length. Well, the other side gives you the length. So you can use that to your advantage. I'll also say he has 3 long bones that are all potentially nailable. But in my practice, there is a 0.0% chance that I'm going to nail all 3 long bones right here and now. And probably only a 40 to 50% chance that he's even going to get 2 long bones nailed. We can probably go into the details of the pros and cons of early total care versus prime non nocere, first do no harm. Ask me how I know. I have caused some significant fat embolism syndromes, and I think it's because I was pushing the envelope and trying to do a little bit too much too soon. So I will always err on the side of being a bit more conservative. That being said, there's also some data, I believe, out of Shock that shows it's actually safe and potentially even safer to nail 2 femurs now rather than staging them. So that's up for debate, and that's the fun of what we do. But gosh, I'm just going to stop talking because I could go all night on this, Dr. Mitchell.
Well, to your point, what's your decision tree then for multiple long bones? So how many are you comfortable doing? Is there an absolute number? How do you check and what do you do to make sure you can proceed? How does that look when you're in the OR?
Yeah, I think it's a little bit different than just looking over the curtain and saying to the anesthesia resident, the CA1, hey, how's he doing? And they're like, oh, he's good. Like, I don't know, my attending's down at Starbucks, but I think he's okay. Yeah, you can keep going. It's more complicated than that. It's not only resending an ABG, checking his H&H, checking the lactate, his overall resuscitative stage. but also the pulmonary pressures, and make sure that we're not missing something and that we're going to keep plowing ahead. And then, oh, wait, we're having a hard time extubating him. Why did y'all do so much surgery? Oh, well, your resident told me he was fine. I do tend to take it slow. And I think in general, patients, families, his parents, if you only fix one long bone and you X-fix everything else, and you explain to them the pros and cons, and we're going to be safe here, we're going to come back in 2 or 3 days, they're always very appreciative, rather than, what? You didn't fix everything today? What are you, crazy? I mean, this kid is critically ill, so I don't have a problem temporizing a lot of these injuries.
Yeah, I think that's one of the fascinating things to me personally about polytrauma is you really have an opportunity. It's so rare in orthopedics to actually affect in a good way or bad way the patient's physiology and their immediate sort of mortality and outcomes. And that's pretty rare for what we do. Most of what we do is function and long-term things like that. So I think that that's a crucial point, I think, to our medical students, is that polytrauma patients, we absolutely affect their physiology with either what we do or what we don't do.
And nailing, instrumenting the canal, the femoral canal, is an incredibly inflammatory event, and so it's important to remember that, different than plating or some of these other operations we do. So, all right, planned surgery, Jana listed here. We IND the tibia, we nailed the tibia as you stated, and then the right side retrograde nail the femur, and then it sounds like your personal long bone limit is 2. That is my personal long bone limit as well. And so if you feel yourself wanting to do 3, just stop. You can always come back. And so here's the setup: intraop, washed and nailed the tibia, nailed the femur retrograde. Just an aside, was that suprapatellar or infrapatellar?
Supra. I don't.
Okay.
I take nails out infra, but that's about it. I'm supra.
The only time I'll do infra is on an up down where it's a shaft on the tibia, so you can put 2, nails in through an incision that big. But yeah, if this is looks a little distal, so I would have supratellar nailed it as well. So during the switch, you check with anesthesia. Again, to Dr. Akers' point, that does mean it's to some degree, hey, how are they doing? But also you've got some other questions that you may ask that's going to be a little bit more in depth. So what things are you looking at outside of them just saying, yeah, his pressure's good, fly away?
Yeah, so I think, your wording and how you ask is crucially important. So you want to know, can you ask them, check another H&H, ask them to check a lactate, ask them how, if you're worried about, fat emboli, ask them how his pulmonary pressures are doing. You have to ask these questions because I think they're not, a lot of times they'll just exactly that say, yeah, he's doing fine, but I don't know what that means. And it's poor communication. And I think your questions have to be directed at what you want to know.
Yeah, often it's like, hey, I'd like a lactate in 30 minutes, please. Or, again, I think in your tone, how serious you are, yeah, we have a lot of fun in the operating room, but these are sick patients. And so it is a little bit more of a serious conversation. So,
And they always seem to switch right when this information is crucial. So I think that's another reason, like they're switching right when something crucial is happening with you, or you're in the middle of switching. And so I think that just highlights the need for communication with anesthesia for these patients, for sure.
Totally. So here's some of the measures that you reported, and I think, again, putting this in your toolbox to say, hey, we actually care about their urine output. That's a surrogate for how they're perfusing their organs. So I think a surrogate for their resuscitation. So lactate gets rechecked. It's at 4. They've been given some fluid, 3 liters of crystal, a liter of albumin, 3 units of packed reds, a unit of FFP, a unit of platelets. That is a lot, and so I think getting that information, knowing the right questions to be asked to say, hey, how much blood have you given? Hey, how much fluid has this patient had? Is critical and can give you a sense to say, actually, although they say they're doing well, they've been fighting pressures for the past 2 hours and haven't said anything to you. And so I think all that is really critical information. So at this point, next step, you've stabilized the right, you've got a left midshaft femur. What do you have the techs getting out for you?
Yeah, I mean, with that information sort of in between checking, then even if I was thinking about pushing my limits, I absolutely would not. I would switch gears to the X-Fix and temporary stabilization for the left with that information and that clinical status on the patient. So that, you know, if I wasn't already thinking it, that pushed me over the edge. I'm definitely thinking it now. Let's just temporize it. It's not just that he's under resuscitated, it's also that he's had a lot of blood loss and we are behind. And it's not as if they're not giving him blood and fluid and or lactates they actively have been trying to do those things. And so that concerns me for just wanting to get done and get him back to the ICU where it can be resuscitated and monitored.
It can always span and fight another day in an expeditious X-Fix, 20-minute X-Fix, no blood loss. This buys you so much time. You put in this image here. I just was hoping you would speak to this as well, kind of a finding intraoperatively.
Yeah, it's not because I like feet. I mean, I'm kind of neutral, but it's because I wanted to make the point that these patients go to the OR, you have some information on their long bones. You don't have all the information. You haven't done a tertiary survey. And that's a good opportunity if you're not in an emergency situation. If you see bruising, to use your physical exam, look for crepitus in any areas that look like they're bruised, range their joints. Even if they're asleep, it's kind of like veterinary medicine. They can't tell you, but you can find objective findings. And if you find anything, just use your fluoro to get an idea so you can formulate kind of a more accurate problem plan for them.
Awesome. Yeah, I like pinning toes, but not that much. So, all right. So now we got a new injury list. We've got a spanned femur on the left and some toes that need pinning. For you, kind of what's the optimal time between this? You've now spanned the next day. General surgery says they're okay to go. Are you taking them the next day? Do you have, for you, is there a standard, or is it a little bit more nuanced, I guess?
It's nuanced, and I will tell you a lot plays into it. Exactly what we were talking about earlier is institutional, either limitations or opportunities. They are temporized, so there's no rush. If they are cleared the next day, their lactate is cleared, their vital signs look good, physiologically they're okay, I may consider. I'd say typically that's not the case. I've already had cases fill up the next day, so I'm tending to wait a few days in between and get them out of the inflammatory window.
What do you think, Ager?
I would absolutely not take him back the next day. And even 2 days would be a stretch for me, but 2 days at the soonest. I think the second hit phenomenon would be most profound between 24 and 48 hours. So probably just give him some time to wake up, extubate, see how he's doing, get a good exam on him. Also, it's a good opportunity to, like Janice said, to do that tertiary. And if you're planning only one more trip to the OR to remove the frame and nail this femur, why not also fix his olecranon while you're there, or pin his toes, or what other injuries he might have? But if you don't know about them, so I like the idea that he's temporized. There's really no rush at this point, as long as he's framed out to length and he's doing okay. Take your time.
Awesome. So immediate post-ops from the next case, another retrograde nail and a nice toe pinning. And here's 1 year follow-up showing the patient going on through radiographic union. So I think, again, coming back to that concept that this is just unbelievable, that we have the privilege to do this. Patient has 3 long bones, and historically this is a mortal event, and now this patient can go back to work. So take home points from this case: multiple long bones can generate massive hemorrhage. A liter in each thigh, tibia half a liter. You can drop 2.5 liters, and although the blood counts may look okay, they need resuscitation, and you should proceed with caution. And so have a long bone limit, whatever it is for you. We all have one, and then prioritize open fracture. So Taylor, any questions to answer?
Yeah, one question that's sort of tangentially related to polytrauma care, especially in a patient like this where there are multiple long bones that you're nailing. How are you getting length, especially in a scenario when there's a lot of comminution?
Yeah, I think Dr. Aker had a great point. Choose the simpler one, and often there is a read that you can have. Certainly, there are going to be cases where both sides are you're not going to have the length, but I would make both legs the same length. Would be a principle. So, Tim, any other thoughts on that?
No, that's it. If you have an intact femur, use that. No matter how much comminution there is, if you have a intact side, you can always restore, you can match that length. And if both sides are smashed beyond any reads, use other clues. I know Dr. Rout likes to talk about the soft tissue tension and the Langer's lines and this kind of stuff. But the bottom line, to Dr. Mitchell's point, is just at least make them the same length. Even if they're off by half a centimeter or a centimeter, if they're the same, it'll be much less noticeable.
Yeah, I
Nice.
think I may be unaware of a paper, but someone posed the question of length from the elbow to the DIP of the little finger, uh, which I thought was fascinating, but I don't think that's one a commonly used one.
That is really fascinating.
But you're using whatever clues you have, essentially.
All right, we're gonna move on to the next one. This is the teaser case. Acre, I've got a lot of information here to make some sound decisions. And so bear with me, team, as we go through this. So the patient, 25-year-old MVC, comes in at 5:30 in the evening. And so here's the initial consult. You know, we get consulted without plain films outside of the AP pelvis with a number of injuries. Here's the kind of initial history and physical from the ER, and I just chief complaint hypotension after MVC. And we don't have to read the rest of that, but maybe that last line, BP was 88/60 on the scene. Here's your initial survey. She has no other x-rays at this point, but she did get scans of the bilateral lowers, angiogram, because obviously each patient may have a extremity that is pulseless, although you can feel a pulse. So this patient got bilateral angios. We see a right tibia, and that's that picture on the left-hand side, an open tibia, a left closed femur, the pelvic ring injury, which was shown previously. And then this is on your initial evaluation, the hematocrit 31, and then you see a blood pressure 82/40. So patient is hypotensive, still being actively resuscitated and worked up by the trauma team. Patient gets a CT scan, and you can see here on that soft tissue window that we mentioned previously, we see there's a blush at the superior gluteal, and this patient has active extrav. And so although they have a complex pelvic ring injury that's vertically unstable with a displaced acetabulum on the left and a ramus on the right, they go to IR at 8 o'clock. So 5:30 initial evaluation, IR at 8 o'clock. And on our IR post IR pelvis, we see a coil's been applied. And then additionally, we see that there's been a pelvic hematoma that's set up shop, displacement of the bladder. We finally get x-rays. This is pretty standard issue here for a polytrauma who's, again, actively being resuscitated. And again, we're just trying to save patient's life. But we see now an open tibia on the right, that kind of type 2, grade 2 open tibia, a left comminuted closed femur, and a first TMT fracture dislocation, no skin threatening. All right, a little bit more information, and then I got some questions. So lactate initial 1.6. You can see the hematocrit's 30, platelets 100. Troponin is 0.96 in this young patient, but I'll note on the CT read, in addition to a liver lac, some pulmonary contusions, the patient also has a sternal fracture as well. So 5 a.m. You get the call, you call the resident calls you. Lactate has now gone 1.6 to 1.2, troponin downtrending 0.55 with a hematocrit of 30. And then I did include some of the respiratory parameters. Here the patient is intubated and setting. Everything's oxygenating wonderfully and doing well. So I'm gonna start with Dr. Aker. He doesn't know this case. And so right open tibia, left closed femur, complex pelvic ring with a bleed. You know, there's bleeding by that sacral fracture, and then a first TMT without skin threatening. How would you sequence and why?
You know, first of all, I'd like to applaud you for not charging into the hospital at midnight because the general surgeons bullied you into putting an X-fix on the pelvis, which is still a common scenario in many centers around the US and around the world. Maybe bully is the wrong term, but strongly suggesting that you need to come in, this patient's hypotensive. But there's a reason why we have algorithms, and it sounds like thus far at your institution, the algorithm is working. I'm sure this patient got nestled up in a binder. they went to, or a sheet, they went to IR. Maybe the sheet was moved down around their thighs to give access to the groin. Whatever y'all are doing, he's still alive and he actually looks pretty darn good. His pelvis right now does not, doesn't even really get my blood pressure up. I think this is for the things that we are doing with traction and percutaneous techniques. I'm just not in a rush to do a whole lot. I do think that this patient is deserving to go to the operating room first thing in the morning. If everything else is, his head CT is stable and clear and he's otherwise stable, to go to the operating room. I think I would probably start with some traction, review the pelvis a bit more. But being able to stabilize this pelvis in a minimally invasive, I'm not talking about an ilioinguinal or a prone posterior approach to the SI joint. I'm talking about if you can get this pelvis lined up pretty darn close with traction and an X fix to manipulate and some limited screws in the back and the front. I think you've really done a ton of good to help limit the bleeding that's going on in his pelvis. And then plus minus the long bones, yeah, at a minimum, external fixation. But like I said earlier, I would always prioritize the femur over the tibia, and then potentially mash on his first TMT and do a toe pinning that I love to do. But I would, again, access to the operating room generally is not an issue at my hospital. So in a couple days, I can come back and nail the tibia, do something more definitive to his foot. But I think stabilizing the pelvis, maybe not the acetabulum yet, that's a whole nother story, but the life-threatening pelvic ring fracture would be the priority, followed by X-fix versus nail of the femur, and then everything else just kind of going on down the line.
In terms of the tibias, the tibias type 2 open, would that be kind of a similar splash and
It
dash
doesn't really
situation?
excite me, Dr.
Doesn't
Mitchell.
excite you.
You're trying to bait me. It does not get my blood pressure up. If it's type 2 and it's fairly large wound, save the money on the $6,000 X-Fix and put a little 6-hole small fragment plate on with 2 screws and 2 screws and put a wound back on, or close the wound and come back in a few days. And if you plated it correctly with just unicortical screws, well, maybe then you just leave the plate on and nail it. There's a lot of options, but no. And you know what? Call me a criminal, but you can wash and close and splint this tibia as well. Splinting is still a way of temporizing these lower extremity long bones, not femurs, but tibias are generally very splintable. So I'm not taking the bait, Dr. Mitchell.
But the first TMT, it's dislocated. No. Okay. All right. Dr. Davis, what would your sequence be?
No, I agree. I mean, I would prioritize the pelvis because that is, even though they were cauterized, like they went to angio, I mean, that's all that cancellous bone bleeding from the sacrum. I think that would be and again, with percutaneous, just get it as close as possible, with percutaneous techniques and then move on to the femur.
I'm so happy right now because it shows that there is multiple ways to take care of these patients. And so again,
But I will say, Dr. Mitchell, I will
Yeah.
say, like 2 slides ago, you had a suggestion that he had like bilateral pulmonary contusions. A pneumothorax in and of itself is not a contraindication to reaming and nailing a long bone. However, pulmonary contusions, depending on how hard this guy's chest hit the steering wheel, you'll see some chest x-rays that are impressive with blossoming. They look fluffed out with these contusions. I would say that is an absolute contraindication to reaming and nailing some of these long bones. And again, this is the doctor in you, Dr. Mitchell, not just the orthopedist. Bone broke, must fix. You really got to look at the big picture and the overall physiology of these patients.
Yeah, I think there's something about being at the bedside too. You'll walk up, you'll go up to the trauma unit and you look at them and you immediately have this reaction to say, we should not nail this patient today in terms of what looks like critically ill. And you got to keep seeing patients. And that's why for students who are on and going to be residents, it's like the more you want a busy night on call, because that's going to your clinical acumen up, and you're able to make some of these decisions. Say, this patient I will be able to tolerate nailing, or hey, this patient's 65 with a cardiac history, they look like death, I'm not going to nail anything today, you know. So it's really critical. So I washed the tibia and then I nailed the femur. And the pelvis was on the radar. I thought we could put it in traction. There, you know, had been coiled to, you know, tidy him up in a sheet, but the femur was the priority. And I think one reason this is enjoyable to discuss, I think some would say wash and nail the tibia first. To your point, this tibia doesn't excite me too much from a physiology standpoint, and the femur certainly was if I could do one operation, I wanted to nail this femur. So we washed and we nailed the femur, rechecked the lactate. Again, we're now sequentially checking in the operating room. What's the lactate? I'm looking at the blood pressure. We're checking the urine output. Lactate's 1.2, hematocrit's 23, and we're okay to go. So I nailed the tibia next. Went ahead. We had washed it. We had prepped both sides, so I nailed the tibia, tolerated that fine. Again, the pulmonary, I put in the pulmonary portion because we're looking at CT scan reads to know what their lungs are like, and again, we're getting information about what their vent settings are before we do these operations as well. And so all this is critical information. Lactate 1.3 after this. Then I hit the toe. Then it was toe time. We pinned it.
Attaboy.
It was
Strong work.
awesome. Went perfectly. You know, best part of the case. And then at this point, if that was an acetabulum that was going to require a couple of hours of work and some additional blood loss, with those parameters, I'm probably waiting. But with a pelvic ring that could be treated percutaneously, we went ahead and through 2 small poke holes did all this, and it's tremendous to be able
ETC,
to.
early total care.
She got the ETC, but we were checking. So these are the final post-ops. We ended up fusing her foot down the line, and she's done well. So take-home points: trauma's complex, evolving, continually reassessed throughout the case. The complexity and the time of the case matters. Again, if that was a transverse posterior wall with, you know, ipsilateral SI widening, no, sir, we're not doing it. But if we can do it in a friendly way to the physiology, and in this scenario, it's almost more of a resuscitative procedure. That's completely different. And then prioritize. What if it's stop? What if they make you stop? So,
Bill, can I just ask, since both
Yep.
Jana and I felt strongly about stabilizing the the pelvis, why did you opt for the femur? You obviously, that it's a great result and you had your rationale, but we felt strongly that the pelvis was potentially more life-threatening. Why did you opt for the femur first?
From a physiology standpoint, I thought the femur was going to have the bigger impact. You know, after being embolized and in traction, things are lined up. Maybe we put a little sheet around it. I think that from a resuscitative standpoint, the screws, as much as I like to do them, if she had an event and couldn't go to surgery for a week and a half, I would be upset that the femur was not nailed. And I can keep her in traction for the pelvis and come back, but that femur, it does make a big difference. So
Yeah, and sometimes you get a sense off from the pelvic fracture, from the 3D recons, just studying these images. Some of these not all pelvic fractures are created equal. Sometimes the hemipelvis will be up in a different zip code and really benefit from going after the pelvis in a more urgent manner. But can't argue with success. This looks fantastic.
yeah, they can bleed quite a bit. And I think that's part of the discussion with trauma too. And maybe in reviewing the CT, you know, there are certainly some findings that you may say, well, we got to bring this sacral fracture from this far apart to this to here, you know. So all right, we're going to run through these last cases and get the main points out of them. This is a case of Jana's, a 39-year-old MVC. We get that AP pelvis, and what do you know? This is the situation where they're doing their ABCs, they do their fast, and patient goes right up to the OR. And so ortho gets called in the operating room. You've got an AP pelvis, but you've got no other imaging. And so here you are. Everybody's looking at you. The X-lap just finished. Splenic lap. They resected some bowel. The fascia's closed, and they want to know what you're going to do with these legs that aren't aren't looking quite right. So Janet,
Don't you love that phone call when there's a bunch of like dead bowel over on the side table and they're like, okay, ortho, you guys want to do anything? Uh, sure.
Yeah, it's never, I mean, nothing's set up typically. I mean, I've had different experiences. One institution I've been at, my current one, they're really good about making sure the table's ready to loosen if they think we're even going to be involved. That's not always the case, depending on the faculty you're working with. So you may be on a table that you can't even x-ray through. So you may be really severely limited with that. If you have the ability or you know about it early enough and can communicate what your needs are potentially for the case, that's helpful. But sometimes you just don't have a chance. You just don't know about it till they're in the OR and they're completely, either the drapes are coming down or they're still draped out, like closing the fascia, and letting you know you have, 15 minutes to do whatever you need to do or something like that. So, but for this one, yeah, we had the AP pelvis, thank goodness. So we kind of knew that we needed to do something on the left side. And then we had our eyeballs to help try to diagnose on our, our palpation to try to help diagnose what was going on. You could tell that there were deformities at kind of both ankles or both distal tibias. And luckily they had put them on a radiolucent table, and we could get shots of the legs. So we knew that he had bilateral pilon fractures and distal tibia fractures, and we knew that he needed X fixes. But the question was, are we going to X fix them right now, or do we just try to sort of line them up and splint them? So I think that for this case, that might be a point of discussion.
Yeah, how do you make that decision for this? If the patient's been in there 6 hours for the bowel resection versus 1, is that a factor, or what's going into that decision?
So I think length of time in the OR and resuscitation status plays into that point for sure. So before you're even considering doing anything, you need the most up-to-date information from anesthesia on how the patient's doing with the lab work, their vitals, with the resuscitation markers, before you can kind of make that decision. I think if they've resected bowel and now they're kind of closing or doing whatever, it's probably been hours that they've been in there, in my experience. And so I'm more apt to just try to get things lined up with the splint. X fixes are pretty quick, but if they're just calling you, you didn't know about it, none of your stuff is ready. You may be working with the tech who's a surgery trauma tech, or who doesn't know the ortho stuff. So I would be more inclined to likely splint these and come back, unless the stars aligned and I could put an X fix on right away quickly. But
yeah, I think having all the information, some of these patients too will have neurosurgical conditions, bad head, bad C-spine, things where being in the OR for longer actually may make a difference. I've certainly been in those situations where we find out afterward, actually neurosurgery didn't want them to even go to surgery, or, said they had a horrible head injury and would like to get them upstairs as quickly as possible. So getting all the information from your trauma team, maybe some of the other teams as well. So
one of the other things, Phil, I'll just say is that the importance of just looking in the mirror and being honest with yourself and being honest with the trauma team. When they say, okay, ortho, we've been in the OR for 3 hours, but do you guys want to do anything? And you say, well, yeah, I would love to X fix these ankles. And they say, well, how much time do you need? Because we got to get him to the scanner for a repeat head CT. Just be honest. If you can X fix an ankle in 20 minutes and you're trying to do both sides, say, I need 40 minutes and we'll be out of here. But then stick to your word. You have to be honest. You don't say, I need 40 minutes. And then 3 hours later, you're still having a hard time putting in the calc pin or messing around. These are sick patients. So again, first do no harm, and then do what you say you're going to do. Don't spend all day messing around. Do what you say you're going to do.
Takes one case to get a reputation, of not doing that. It just takes one. The whole trauma unit's talking about Mitchell. Yeah, he said it would be 20 minutes, but it was 3.5 hours.
Just add a zero to that.
Exactly. When it's Mitchell, just add a 0. Yeah. So y'all splinted, got tension off the skin, and came back to fight another day. So you get some formal x-rays. And again, that's when we kind of start the discussion with general surgery. When are they safe? And communication for these types of cases is maximal, right? This is not the perc pelvis acetabulum. This is going to be a little bit bigger. This is going to be a little bit more blood loss, a little bit longer. And so you're and constant communication. So that determination for when to go to the OR, it's not cookie cutter. It's not a cookbook. It's often a discussion. So you've got these two ankles, Jana, and then you've got this acetabulum. How are you sequencing these in an ideal world?
So for this fracture, so just to back up really quickly, when he's in the OR with general surgery, I'm putting a traction pin in on the left after making sure he doesn't have a femur fracture. So that gets the femoral head sort of and the medialization sort of taken out of the picture a little bit. So I would have done that kind of when he was in the OR, if we had the or if we couldn't and we had to leave the OR quickly because we didn't have time, pretty quickly when he was in the ICU. For the definitive surgery for this one, I do my acetabulum fractures prone. This is probably a several trip situation for me. So I would like to get this Pilon's X fixed as quickly as possible, just for the soft tissues and swelling and soft tissue control. So I'd probably return as soon as I could for that, and then come back for the acetabulum.
Yeah, I think a similar sequence. It is something to think about if you've got a plateau with pins and in the femur, and you're going to go prone for the acetabulum. There are things to think about on that. But for this, frames both ankles. Step one, depending on the day, the availability, may tackle the acetabulum on that day. May wait a day or two. This is one that's going to take some love. So. Framed the ankles. A couple of days later, came back and fixed the acetabulum with this construct here. And so here's our timeline. You splinted the first night, bought time, got resuscitation, post-injury day 1, X-fixes, got CTs, more information with definitive fixation for those down the line, and then fixed your acetabulum post-injury day 3. And so take-home points on this case: the clinical status of the patient and the soft tissues determine early definitive fixation versus X-fix. You can always temporize. We talked about it a few times tonight. You can always fight another day. And then when you collaborate with colleagues, things get more complicated, or they can. And so again, communication becomes even more important. What table you're on, what instrument you're using. Are you going to use X-ray? These types of things can make a big difference in terms of a Pilon X-fix taking 20 minutes or 2 hours. Some of it may be determined by those factors. So Taylor,
Would
any
anybody
questions?
have done a different order? Would anybody have done anything differently?
No, same thing. I think the only question is one setting, and for a case like that, the acetabulum, it's going to be a little bit more intensive from a use standpoint. So I think choosing a day where you're going to be able to dedicate the time and the resources to make it perfect is what I would say is most important. So. All right, we got 2 more. If you guys will stick with us, and these are absolutely amazing cases. So, Taylor, anything?
Questions wise?
Yeah.
We'll touch on it in this case, I think.
Okay, great.
So yeah, this is
of Taylor's, and I just have to, this is some great trauma, great polytrauma case, and I think there's a lot to take from it. So, Taylor, walk us through. I'm going to click through all the associated injuries.
Yeah, it's a middle-aged female in an MVC. There was clearly high energy with fatalities on the scene. The labs here, you can see on the left, the lactate's 3.7, the base excess is negative 8.1. So you get a sense that the patient is not completely resuscitated, certainly, and the platelets are trending a little lower. H&H look relatively stable. You see a severe open injury to the right lower extremity, and you see a really bad looking knee x-ray there. Should make you start to worry about sort of a knee dislocation variant and any possible compromised vascular status to that limb, which would be certainly an emergency, but also the degree of contamination, the degree of openness of that open knee injury there is something to be concerned about as well. And then obviously you want to get that hip reduced, but you're starting to prioritize these things in your mind as you're looking through all these various x-rays. And you can see we did get a traction pin in the femur over there at some point, but you also see a few more of the other injuries on the left lower extremity. You got a talar neck fracture, another tibia fracture. You have the pelvis shown here again, showing that acetabular fracture. And then you also have some upper extremity injuries, which we'll get at a question that Michael had about prioritizing lower extremity versus upper extremity. And in this case, the patient's got an open distal humerus as well as an open distal radius with an ulnar nerve transection. And so then you can see the litany of injuries here. We really have to think about how are we going to tackle things. And so for me, this patient generally goes overnight. She came in pretty late, around 11, and that's a time frame where I'm not really going to wait till morning to get to that with that sort of X-ray of that right knee. That's probably the one that pushes me over the edge to say this needs to go that night, even with those labs being somewhat not all the way resuscitated, but you're making sure that that resuscitative process is ongoing as you're tackling this patient and provisionally stabilizing the multiple injuries, because that can also help with the resuscitative status like we talked about. And so the priority for me was that right lower extremity injury. And so we did an irrigation and debridement of that knee wound. We did put in some antibiotic beads. We'll put a wound back there. We'll put an X-fix in place as well to reduce the knee. You can see the alignment is better. Surprisingly, the vascular status was actually not compromised in that setting. And then, like Dr. Aker mentioned before, we put on what we call a damage control plate, unicortical screws somewhat anterior on the shaft, so that we may nail that injury later if we elect to. But that would be a challenge. It's not in my skill set to nail this injury with that tibial plateau injury above. But we also did a DCO plate on the left side as well, and splinted the foot and put traction in to reduce the hip, washed out the elbow and the distal radius, tagging the ulnar nerve for a hand surgeon to repair later, and splinting those extremities as well. So we've sort of washed all the open injuries, made sure they got antibiotics, tetanus, and then everything is sort of provisionally stabilized for the time being.
How long did that take?
That took a while. That took, like, I think 5 hours, probably five.
That's so important, like to do a thorough debridement of that many open fractures and stabilize going in at 11. It's like this, I'll be here all night doing this, and that's what needs to happen. But I think understanding that this is, a critical step in this patient's care, both to close their open wounds, make sure the debridement reasonable, and now you're in a position where you got time on your side. You've taken care of these emergencies. But yeah, that's critical. That looked like about 4 to 5 hours of debridement and closure if you're doing it the right way. So,
and like you said, we're in constant communication as we progress from extremity to extremity. Should we stop, sort of thing, with our anesthesia?
yeah, I think there's gonna be active bleeding from a lot of these wounds as well. So getting continued resuscitation while the patient, don't just throw a towel over that tibia and wash out everything else while it's bleeding onto the table and you're losing, half a liter. Prioritize and execute. So post injury day 3, you nail the tibia and repeat debridement for the right leg. So I guess just why this tibia first? Why not that right side looked worse? How was this decision made?
Yeah, the right side was going to be a complex surgery. I knew that would take me a lot of time, and also the degree of contamination. The need for plastic surgery was pretty much inevitable in that case, and so we're not going to really do anything definitive until we know we can have coverage shortly thereafter. We don't want to put plates and screws in and then put a vac on unless we know that coverage is going to happen pretty soon thereafter, because the data would suggest that can be associated with a higher risk of infection, especially with an injury like this. So we nailed that other tibia, like you said, washed the right side and put new beads in, and then continued to allow her to convalesce. And then, as you can see on the next day, plastic surgery did do the distal radius. That's probably an institutional phenomenon. I would say that's probably a lower priority injury to stabilize, but it depends on your institution and who's available when, and what teams are available to do those things. And then on day 7, repeat irrigation debridement and then definitive fixation of that right lower extremity. And as you can see, that I ended up doing a series of plates to fix that injury, and then on the femur side, just some screws to avoid excessive service implants, which I probably already have and then put a bunch of antibiotic cement to fill the bone void there. And then in the same setting, the exact same day, fix and flap. So plastic surgery did a rotational coverage with a gastroc flap there.
Awesome. So then hospital day 11, y'all fix the acetabulum and the remainder of the right tibial shaft, and then polish it off with the distal humerus on day 14. And here's this patient. I don't know how far out she is now, but again, just coming back to how incredible it is to be able to do this to those degree of injuries to where this patient now can live a functional life. So take home points, you can have intraop resuscitation. And so for a case like this, where they need to go overnight, whether it's a wound issue, whether it's compartmental syndrome, you can resuscitate while you're in the operating room. There are orthopedic emergencies that need to be prioritized. And then finally, the impact of coordination. So in this case, plastic surgery, timing of coverage impacted how this patient got taken care of. And so bear with me 2 minutes because this case is really important. And this is going to give Tim a lot to think about, want to talk about, and then we're going to have to stop, and it's just torture. But this is a patient, 54 years old, segmental femur open with an intra-articular split on the left side. Left side segmental tibia, right mid-shaft femur. And I just want to really highlight on this here, and this for our residents is important in preoperative planning, that if you measured her isthmus, it measured up between 6 and 7 millimeters of her femur. Her tibia measured 3 millimeter isthmus. And so I haven't seen that many patients with these toothpick bones, but this was one of them, and she just happened to have multiple injuries. And then she had a humerus and an ulna on this side. And so I'm going to cut right to the chase. The plan was to wash and fix the open femur, and then potentially to plate the tibia in the setting of a bone that was not nailable because of its diameter, and then consider the upper extremity. So this is the case. We started at 12 p.m. when she was cleared. Her lactate was 1.6 at that time. As we're kind of working our way through the femur, sure, lactate comes back at 2.6 at 1 p.m. We're kind of piecing together the distal femur at this point. We finished the femur at 2, and her lactate's 2.2. They're okay proceeding. We're starting to downtrend a little bit. So I MIPO the tibia with these plates, and we fixed the upper extremity at the same time. So lactate ending at is 1.17. So all we've got left right now is a right mid-shaft femur with these fractures stabilized. And so I bring this case up because the lactate's downtrending. Certainly her resuscitation is heading the correct direction. But this was an important case, I think, and one that I like to show because I mentioned it before, instrumenting a femoral canal is uniquely inflammatory and has unique risks that may not have to do with resuscitation. So, it's 4 o'clock. She's okay to go. So we elected to proceed and nail the femur, 30-minute retrograde nail. She'd be done. So we get started. Again, her isthmus on that other side was pretty small, so the reaming was fairly traumatic. And as we passed the guide wire across fracture and past the first reamer, her pressure drops and she codes. And we put a nail up. Don't interlock it. We put a nail up, chest compression. She comes back pretty much within the first round. Very suggestive of fat embolism. And we ended up putting in the interlocks a few days later. But I bring up this case again. Have a long bone limit. For me, it's 2. But if the isthmus is this tight, it's 1. Now it's 1. So Tim, I want to let you say something because I think this case is really critical. I put it last for that reason. Fat embolism is real. If you're on the fence, just temporize and do it another day. So I'm going to have Aker say something.
Well, I think we've been dancing around it and said it all night. Janice said it as well. I mean, we're physicians, we're physicians first, and also orthopedists. So first, do no harm. And I've rarely been burned by the patient that I've had to bring back to the OR 2, 3, 4 times, but often been burned by the case where I've tried to push the envelope and do too much too soon. It's rare in the world of orthopedics or even orthopedic trauma that you truly can make a difference in whether the patient lives or dies. And this is just a prime example of seemed like everything was going fine. I mean, I don't disagree with your decision making. But the retrospectoscope is also very revealing, So this is the practice of medicine and live and learn. And I'm glad she did okay.
Yeah.
I think she survived. I don't know if she's okay.
She did. Yeah, we still, it's amazing that she's very interesting in terms of having every complication you can imagine. This nail ended up breaking and coming in at 3 weeks, and she was about 4 centimeters short. So some social challenges as well. But yeah, I think again, coming back, there's data again, bilateral femurs is safe, but this is not that case. This is toothpicks for bones. This is reamer, the drill is so hot, that kind of thing. So every time you pass it, you're doing damage, So I think it's a case that I bring up a lot, and she certainly has been important, I think, patient in terms of my practice. So consider more than just the lactate for this. So next month, we're talking about complications. I want to thank Taylor, Tim, and Jana. This has been a lot of fun. I mean, we went a little over. I honestly think we could go for another hour and 15 minutes without any loss of enthusiasm. And so, again, we're grateful to everybody who tuned in. We love doing this. Trauma's awesome.
Bill, if I could just make one other comment,
Please.
actually 2 comments. One, for those students that are going into orthopedic surgery as a career, congratulations. I mean, this is perhaps the biggest week of your life, finding out if you matched. And for those MS2s and 3s, you'll know that feeling in one short year. But congratulations. It's a pretty awesome club to be a part of. So strong work. But also then the next thing I'll say is that I know it feels like tomorrow when you open that envelope, you've crossed the finish line. And I agree with Jana. Enjoy it, celebrate, pop some bubbly, have a good time. But just keep in mind that we've only just begun. I mean, it might feel like you've hit the finish line, but it's actually it's like the starting gunshot of a marathon. And so a lot of medical schools have a couple months of the end of your 4th year to kind of go on easy street and kind of take it easy and vacation. And you should enjoy it. But some of our highest functioning interns are also the ones that use that time to open a book, do some reading, do some studying, read some journals, even if it's on the beach, wherever you're relaxing, because it is a marathon of a career. And it's never too soon to start getting more involved. Also, the other big news that I want to share is that a couple meetings that we've been in recently, the AO link has been re-upped for next year. So whether you're a student that's engaged in this and you're going to stay a student, or you're a 4th year that's about to become an intern, you are welcome to come back and join us. Next year, the topics are not going to be exactly the same. They'll be evolving just to keep you on your toes and keep you interested. But those are just a couple of exciting updates that I wanted to share, Phil. Thanks for the mic.
That's it. Thank you all so much. This will be on YouTube if you want to view it again, and we'll see y'all next month.